Assalamu alaikum and good afternoon, ladies and gentlemen. Uh, this session is going to be for the diagnosis of glaucoma, and the diagnosis of glaucoma obviously starts with the history, and then general physical examination of the patient, and then clinical examination of the eyes, and then comes the relevant investigations. So I'm not saying through this presentation that OCT would be the first test for any kind of glaucoma suspect. It is going to be the last test. It's not going to be the first test. The first thing will be obviously history of the patient. Like in any diagnosis of any part of the body, we always start from the fundamentals. So after we have done the history and examination, and there is strong suspicion of glaucoma, and you have ordered for the visual fields, and the visual fields come out to be normal, and but the history, the clinical examination of the eyes, the intraocular pressure is borderline, or there is family history which is very strong, the patient is myopic, the patient has got central corneal thickness which is low. So there are all features which prompt you to go further ahead for investigations and not just rely on the visual fields that it is normal, therefore the patient will be normal. And secondly, the patients who have a family history and they come to you for a confirmation or something declaration that I am not, since my mother has got glaucoma and my grandmother also had glaucoma, I want to be sure whether I have glaucoma or not. So she can be in a pre-perimetric stage of glaucoma, and unless you do the OCT, you cannot say confidently that you don't have glaucoma. You can't say this statement, which is very crucial. Saying anybody that you are glaucomatous is very serious thing, but also saying anybody that you are not glaucomatous is again a very serious thing. You have to rule out so many things before you finally give this verdict to any patient that you don't have any problem, because in future, if the patient gets relaxed and doesn't bother about getting the eyes checked, that I've got a declaration from a very senior ophthalmologist or any competent ophthalmologist that I don't have any problem, I don't need to get myself tested every year or every 2 years. So OCT, as I mentioned, would come into play when we want it to be used for the patient and sensibly, because everything has a cost, and you need time, and the patient needs the patient also needs time and money to get these tests done. It's a game changer in diagnosing pre-perimetric glaucoma. Usse pehle, when we used to have, there was no OCT, the patients would be diagnosed when there is 30-40% loss, which is already done to the patient. Only then the patient will be diagnosed as a case of glaucoma. But with the advent of OCT and rational use of OCT, we can diagnose the patients very early. It's a non-invasive imaging test. It's a non-invasive. I also mean that visual field is itself is a test in which the patient involvement is too much. The patient has to press that button, and the false positives and false negatives. We will be talking on the visual field tomorrow morning. We have an instruction course in Shalimar Hall on visual fields, update on visual fields, where we'll teach all the residents how to read the printout of the visual field, and also what are the new modalities of the visual field. So that we will discuss tomorrow morning at 9 a.m. But OCT is a non-invasive thing. It doesn't involve the patient. The patient just has to put the chin on the rest of the machine, and then the machine takes control of everything and gives you the report, which you have to interpret yourself. High-resolution cross-sectional images of the retina detects RNFL thinning before visual field changes occur. Monitoring of progression of glaucoma and differentiates between healthy and glaucomatous eyes. This is the one example that I was showing to you, that you can see that the disc looks a lot of the glaucomatous, but the visual fields come out to be almost normal. There is some very little changes, but the report is normal. The global values indices are also normal, and you get the OCT done, and OCT comes out also to be normal in this patient in the green zone. So sometimes when you are suspecting glaucoma and the the patient is non-glaucomatous in both tests, the visual fields as well as OCT, then the patient is clear for, and this is a sort of physiological cupping or prominent cup of a prominent disc, large cup of a large disc. And on the contrary, you see that, and on the same thing, that the patient's is positive in visual fields and also positive in the OCT, and both the reports are matching with each other. इसमें भी कोई मसला नहीं है. मसला वहाँ पड़ता है कि जहाँ पे शक है लेकिन और विजुअल फील्ड्स में नहीं आ रहा और OCT में आ जाता है. तो फिर हम इसमें बात है, ये दो एग्जांपल मैंने इसलिए दिए हैं कि एक में बिल्कुल नहीं है और एक में है, तो दोनों में है. ठीक है. So OCT in glaucoma we do for RNFL, retinal nerve fiber layer, and also for optic nerve head. The fast RNFL thickness scan performs 3 circular scans of 3.4 diameter around optic nerve head with 256 scan points, and the RNFL thickness scan 3.4 performs 512 points, and the most commonly used scan type for clinical assessment is fast RNFL. अच्छा, अब ये प्रिंट आउट है. अब इसको इंटरप्रेट कैसे करना है, ये स्टेप बाय स्टेप है. इसके 4 स्टेप्स हैं जो आपने करने हैं, और इसका पहला स्टेप ये है कि यू आइडेंटिफाई द स्कैन टाइप, कि फास्ट RNFL है या RNFL है. तो फास्ट RNFL, और ये दिस थिंग इज रिटन ऑन द प्रिंट आउट, एंड यू जस्ट हैव टू नोटिस इट एंड रीड इट विच स्ट्रेटजी इज बीइंग यूज्ड, एंड यू कैन सी दैट इट इज रिटन देयर RNFL thickness map. So it's not fast, so it will be using 512 points. So to start with, you should identify the scan type. The second step is to check the scan quality and signal strength. This is very important. This is like a visual field, false positive and false negative, whether this report is reliable or not. Only 2 days ago, I received a patient in the clinic where the patient had a bunch of OCT reports done over time, and all showed red zones and the yellow zones, and lot of anxiety by the patient and the family. The patient was youngish, about 42 or 43, and 90% of the reports were below the normal signal strength level, and I straight away rejected them and asked him to get a fresh scan with a high signal strength, and by high signal strength should be above 5, minimum above 5 out of 10. 6, 7, 8 is a very good figure, but because of pupillary problems or media opacity, sometimes you should be able to explain it, that why the signal strength is low. You should have the explanation. If there is no explanation, it means that the report is not done properly, there is centering problem or something else. The values of signal strength range from 1 to 10, with 10 representing the strongest and 1 representing the weakest signal, and the value of signal strength is directly related to RNFL thickness. I'll show you in the example how the RNFL thickness varies with the signal strength. And this is there, signal strength is also written on the report. So first thing to see is the scan type. Second thing is to see the signal strength. On the right side it's 9/10, which is very good, and on the left side is 3/10. And you can see that right side is showing 100% healthy and left is showing diseased, and signal strength is also low. So you should have an explanation why it is low. Unless you have the explanation, it will not be reliable. And see this picture. The signal strength is 5. The RNFL thickness comes out to be 97. And when the signal strength goes up to 10, the same patient, RNFL thickness comes to 118. So there is a difference of 21 microns on the basis of just the signal strength. So as the signal strength is increasing, the RNFL, the accuracy of the report is also improving. Therefore, you must look at this. The third thing is the third interpretation step is the check the scan position. This is essential to position the center of the scan circle. Previously जो scan आ रहे थे उनमें ये था कि एक स्टार नजर आता था, पेशेंट सीधा मुंह रख के बैठा हुआ है, उसको कहा जाता था कि साइड पे जो स्टार है उसको देखो. अब वो बड़ा मुश्किल होता था पेशेंट्स के लिए, क्योंकि हमें आदत होती सीधा देखने की, ऐसे देखने की नहीं. तो उस स्टार को देखो, तो वो जब स्टार को देखते थे तो उसका डिस्क सामने आती थी तो उसका स्कैन लिया जाता था. अब जो नए वर्जन आ गए हैं उनमें ये चीज़ खत्म हो गई, ये प्रॉब्लम अब खत्म हो गई है. अब पेशेंट ने सीधा ही देखना होता है, तो वो मशीन खुद उसके डिस्क को डिटेक्ट करती है और उसको साइड पे रखती है. तो स्कैन सर्कल शोन एज अ वाइट सर्कल इन द printout serves as a reference to identify scans with poor centration. Display scan results in global and sectoral RNFL measurement errors. ये देखें आप कि अब इसके अंदर ये डिस्क है, तो इसका स्कैन ऊपर शिफ्ट हुआ, और ये डिस्क है और इसका स्कैन नीचे शिफ्ट हुआ हुआ है, तो ये फिर रिपोर्ट्स जो है ना उनमें एरर रहेगा। जैसे ब्लू लाइन नॉर्मल है और रेड जो है पेशेंट की अब नॉर्मल आ रही बिकॉज ऑफ द पुअर सेंट्रेशन। सो चेक द स्कैन पोजीशन इज द इम्पॉर्टेंट थर्ड स्टेप। ये इस तरह अगर हो तो ये ठीक है, लेकिन इन ये जो सारे 3 कलर्ड रिंग्स हैं ये सारे एक्यूरेट नहीं हैं। तो अगर पेशेंट की इस डिस्क की पोजीशन स्कैन करते हुए इनमें से किसी पोजीशन पे आती है तो वो फिर रिपोर्ट रिलायबल नहीं होगी। अगर इस तरह आती है कि जो डिस्क के चारों तरफ तकरीबन बराबर का फासला है तो उसको आप एक्यूरेट समझेंगे और वो रिलायबल होगा। द फोर्थ थिंग इज evaluation of the RNFL in quadrant and clock hour pattern. The normative database consists of 328 normal subjects fast RNFL पे। ये सारे सिर्फ इसमें 8 हैं जो इंडियन ओरिजिन के हैं, बाकी सारे मुख्तलिफ रेसिस के हैं, इसलिए ये जो डेटाबेस है ये भी कोई इतनी हमारे लिए रिलायबल नहीं है। द कलर कोडिंग सर्व एज अ यूजफुल रेफरेंस, excuse me, the color coding serves as a useful reference for clinical evaluation. If it is green, it's within 5%, 95% of normal distribution. Yellow is 5% of normal distribution, and red is 1% of normal distribution. तो ये वेव फॉर्म, क्लॉक आवर्स और क्वाड्रेंटिक, ये तीनों आपने देखने हैं। इसमें ये जो सारा पिक्चर है ये नॉर्मल है और ये जो ब्लू लाइन है ये पेशेंट की है, उस पेशेंट की, ये राइट आई ये लेफ्ट आई। तो उसके हिसाब से ही क्लॉक आवर पैटर्न के अंदर चेंजेस आई हुई हैं और इसी हिसाब से क्वाड्रेंटिक पैटर्न के अंदर चेंजेस आई हुई हैं। तो यू कैन सी दैट द वे द वेव फॉर्म इज़, और वेव फॉर्म जो है उसमें वही इजेंट रूल आता है, इंफीरियर सुपीरियर नेजल टेम्पोरल, और उसके थ्रू ही आपने एसेस करना है। ये भी वही चीज़ है जो मैंने पहले बताई है। तो समरी ये है कि 4 स्टेप्स हैं। स्टेप 1 इज आइडेंटिफाई द स्कैन टाइप, स्टेप 2 is the signal strength, step 3 is the centration of the disc, and step 4 is the interpreting the waveform, clock hour and quadrantic. Now I come to the optic nerve. अभी ये मैंने जो बताया ये सारा RNFL था। अब ऑप्टिक नर्व हेड का एनालिसिस है। इसमें यह कि इसकी नॉर्मेटिव डेटाबेस भी नहीं है हमारे पास, तो नॉर्मेटिव डेटाबेस नहीं है तो फिर इसको किससे कंपेयर करेंगे। और एक ये कि पीडियाट्रिक पॉपुलेशन में भी हम कहते हैं कि जी इसका कोई फ़ायदा नहीं है। मैं वैसे पीडियाट्रिक पॉपुलेशन जो बच्चा कोऑपरेटिव होता है उसका स्कैन करता हूँ जहाँ पे मुझे ज़रूरत होती है, उसके अपने स्कैन्स को आपस में कंपेयर करने के लिए। बेशक के नॉर्मेटिव डेटाबेस में 12 साल या उससे ऊपर के बच्चों का भी नहीं है, अडल्ट्स का है सिर्फ, लेकिन पेशेंट के आप अपने डाटा को तो कंपेयर कर सकते हैं ना। तो आप अपना उसका कर लें, उसके साल बाद रिपीट करें तो देखें कि प्रोग्रेशन क्या है क्या नहीं है, अगर उसकी स्टैंडर्ड के साथ नहीं भी मैचिंग हो रही तो। 6 इवनली स्पेस्ड लीनियर स्कैन सेंटर्ड ओवर द ऑप्टिक नर्व हेड आर क्रॉस सेक्शनली एनालाइज्ड, और OCT ऑप्टिक नर्व हेड एनालिसिस में ये सब चीज़ें एनालाइज होती हैं। इंटीग्रेटेड रिम वॉल्यूम, इंटीग्रेटेड रिम विड्थ, डिस्क एरिया, कप टू डिस्क वर्टिकल हॉरिजॉन्टल एंड एरिया रेशियोज एंड कप वॉल्यूम। और ये इस तरह से सारी रीडिंग्स आ जाती हैं जिनसे आप एवेलुएट कर सकते हैं कि ये नॉर्मल है या नहीं। Artifacts should be taken into account and clinical application of OCT for optic nerve head analysis has been limited by the lack of normal, जो मैं ऑलरेडी बता चुका हूँ। Conclusions are that clinical evaluation is the most important parameter in the diagnosis of glaucoma. Borderline diagnostic dilemmas and pre-perimetric stage diagnosis are to be achieved with the help of OCT. Follow-up and monitoring requires reliance on both visual fields and OCT. And interpretation of OCT like visual field is to be done step by step. Changes in the visual field should complement changes in the OCT after it has become perimetric. Till the time it is pre-perimetric, you cannot compare anything with the visual fields. Anterior segment OCT has a future role and utility. इसके ऊपर अलग से भी एक वो है कोर्स। So remember these steps, the 4 steps that I already mentioned, and thank you very much for your presence and attention.
Thank you very much, sir. We'll take the question and answers in the end. The next presenter is Dr. Huma Shahid. Dr. Huma Shahid is a consultant ophthalmologist from UK. Thank you very much, Dr. Huma, for coming all the way from UK to deliver your talks.
Very nice to be back in Lahore. I'm really pleased to see that we've got two talks this afternoon on gonioscopy. So in Professor Butt's talk, in his conclusions, he mentioned that clinical evaluation is the fundamental, plays a fundamental role in the diagnosis of glaucoma. And I would say that you cannot really call yourself a glaucoma specialist unless you can perform accurate gonioscopy and that you utilize it. So just to set the scene, again, we've heard some of the epidemiology, but worldwide, after cataract and refractive error, glaucoma is the commonest cause of blindness, the third commonest cause of blindness, and the commonest cause of irreversible blindness. 7% of blindness in people over the age of 30 in Pakistan is due to glaucoma. Apologies for the missing word on the screen here. But essentially, a lot of people think, well, why should I bother to undertake gonioscopy? So there are lots of reasons why people choose not to perform gonioscopy. It takes time in a busy clinic. People will say, well, patients don't tolerate it. It's difficult to do. I don't know what I'm seeing. I was never taught correctly. There was a survey that we did in the UK a few years ago. And in that survey, about a third of training ophthalmologists only a third felt that they were comfortable with gonioscopy, and 10% of them said that they'd actually been taught how to do it properly. So there's a huge gap, and it doesn't matter where you are in the world. I think the problem is universal. So, I mean, from my own practice, gonioscopy has to be done in every patient, every new patient that we evaluate, and then at intervals thereafter. And the reason for that really is without gonioscopy, you cannot truly classify glaucoma, and you will miss secondary causes of glaucoma, particularly in the realm of angle closure. So chronic angle closure glaucoma, while not being the commonest cause of glaucoma worldwide, is the most common cause of vision loss in this area. And gonioscopy really is the key to its diagnosis and management. And again, the commonest cause of an incorrect diagnosis will be that you have not examined the patient fully. So the next question is really, does it matter what lens I use? And in short, the answer is no, it does not matter. If you have a gonioscopy lens, if you have a 3-mirror lens, if you've got a contact lens, whatever lens you have, just practice using it and be confident with it. So the lenses that we use in the clinic, so with the slit lamp, are all indirect gonioscopy lenses, and I'll come to the difference a little bit later. So of those indirect lenses, you have lenses where you need to use a coupling medium, so some gel or a viscous medium, and you've got lenses where you don't need a medium. So when you're learning how to do gonioscopy, or if you're not confident, I would suggest that you use the ones that you do need to use gel with. Number one, they're much more stable on the eye, so you can actually take your time and look at the angle structures more carefully. You can often get a better view as well. The only difference between those and the ones that are the smaller contact area lenses are that you can't indent, but you can learn that as a later skill once you're more confident with your more stable lens. And just coming to indentation, so with lenses that indent, the area in contact will always be smaller than the corneal diameter, and essentially you are pushing on the cornea to open the angle, and it will let you determine whether you have synechial angle closure or whether it's simply appositional closure. So there are important distinctions that you need to make. So we were talking about indirect lenses. So by definition, most of the indirect lenses will actually invert the image that you are looking at. So when you look at the retina, your lenses, everything's upside down and left to right transposed. But with a gonioscopy lens, although what you're seeing is the opposite, it's not inverted left-right, so they're not laterally inverted. So in this image of the eye, if the mirror is at the top, then what you see, you'll be looking at the inferior angle. So it just gives you the corresponding numbers as to what you're seeing if that's the view through your lens on the left. So one of the key things with gonioscopy is to tell the patient what you're doing. If you engage the patient and you explain really carefully that you are going to be using a lens, it is going to come close to their eye, it is going to touch their eyelashes, it's going to feel really strange on their eye, then they're much more likely to be cooperative. If without warning you're just going to attack them in their eyes with a lens, then they are going to struggle and you're going to struggle. So you do nobody any favors. Use low-level lighting. So what that does is it avoids light entering the pupil and causing miosis. You're more likely to get a physiological opinion or impression of the pupil. Use a higher magnification so you can look in detail at the angled structures, and use a short height beam. So these are some images that show the impact of light. So if you're doing gonioscopy in a bright light setting, then what will happen is that the pupil will get smaller and the angle will artificially open. So you may think that this is an angle closure, but under a physiological setting, you will have some degree of angle closure. There are some techniques that you can use when you're a little bit more experienced and you can handle a lens on the eye. The corneal wedge is a useful technique, particularly in patients with less pigmented angles. I don't have a lot of experience with Pakistani patients, but if that's a problem here as well, maybe amongst northern races, then this can be really useful. So when you do the corneal wedge technique, you want to use a very bright and very thin beam of light. And when you shine it through, what you'll see are two lines of light. So one of the lines will be much more distinct, and it will be passing over the iris and into the angle. And there'll be another broader beam that you'll see that's passing over the cornea. And where the two meet, I don't think I've got a pointer, but anyway, where they meet, they form a V, and the base of that V will be at Schwalbe's line. So what I would suggest is you do gonioscopy in everyone, and just as you get more comfortable, you just practice this technique, and then eventually you will learn to appreciate the nuances. If you can't really see the angle structures because the iris structure is more convex, ask the patient to look just slightly towards the mirror. So if your mirror is at the top, just say, look up a little bit. And similarly, if the plane of the iris is flat, you can get them to look a little bit away from your mirror, and you'll get a view that's more parallel to the iris and better image quality. So just a simple picture of a very good picture of what you'd love to see when you're doing gonioscopy. And I used to have a colleague who used to talk about tiramisu. So he always used to say, oh, look for tiramisu, the brown and white layers that you get in the pudding. And initially when you're starting out, that's all you need to look for. Just look to see, can you see brown and white lines in the angle structures? And then gradually you'll be able to appreciate, which line is the trabecular meshwork, what's the scleral spur, where's the ciliary body. Ciliary body is always the closest to the iris. There are different ways of classifying the angle. Personally, I use the Schaefer grading scale. You need to beware the Shea scale, which uses numbers, but it's actually the reverse, but in Roman numerals. To be fair, what most people tend to do is that they either use Schaefer or they will just document the most posterior structure that they see. And that's a really good way of communicating to people what you're actually seeing. It doesn't matter what grading system you use as long as you document carefully. My personal this is a rule that I use. An occludable angle is an angle where the pigmented trabecular meshwork is not visible in 3/4 of the circumference. For research and for many of the guidelines, what you'll find is that they use 180 degrees, so half of the circumference. And it's important to think, well, if I identify a narrow angle, that doesn't mean that patient has glaucoma. And there is no test that is sensitive enough or accurate enough to identify which eye with angle closure that you've identified on gonioscopy is going to develop glaucoma. We still can't predict that. But in retrospective studies that have been done, 2 quadrants of angle closure is a risk factor for progression to later surgery. We've got lots of new imaging techniques. Again, they do not replace clinical examination. Somebody very nicely described gonioscopy as, imagine that you're standing on the lens and you're poking your head up in through the pupil, and you're actually looking around. So you can look 360 and actually physically look at the angle structures, because imaging is great, but there are certain features that you cannot identify in the same way that an OCT scan is not going to pick up a disc hemorrhage for you. We have classification systems for angle closure. I won't go into these too much for time purposes, but these are all widely available in the guidelines for glaucoma. These are some of the features that you may well see on gonioscopy. Iris processes are present in about a third of normal eyes, most prominent in childhood and in brown eyes. And they're essentially just small extensions of the anterior surface of the iris. They insert at the level of the scleral spur and cover the ciliary body to a varying extent. They shouldn't be confused with peripheral anterior synechiae, which look slightly more different, are often more irregular, and often a sawtoothed pattern. Pigment dispersion. Sometimes you may see pigment dispersion before you identify pseudoexfoliation, as we've just had a talk on pseudoexfoliation. And often, much of the pigment within an eye can be lost. So often the angle examination is really crucial to diagnoses of these conditions. If you don't perform gonioscopy, you will not identify new angles in the new vessels growing in the iris, which can happen in neovascular glaucoma. And certainly just over 10% of eyes that have angle neovascularization will not have any signs of vessels on the pupil on anterior segment examination. Blood vessels can be normal in the angle. So again, the more you do gonioscopy, you'll get to appreciate these features. And, if you've got light colored eyes, 60% of patients, you can see blood vessels because the iris is much thinner as well. But any blood vessel that crosses the scleral spur onto the trabecular meshwork will be an abnormal vessel. Many patients can present to you with trauma. Blunt trauma will cause angle recession. Incidence is quite high if you've had a high femur present. And again, that can lead to angle recession glaucoma in the future, although the risk of that is reasonably low. And again, gonioscopy will let you identify the widening of that ciliary body band. Surgical gonioscopy, I'm not sure how many of you are using MIGS procedures, but if you can't do gonioscopy, you're not going to be putting any of these devices in because they all need gonioscopy. And surgical gonioscopy lenses differ from the indirect lenses that we use in clinic because they give you a direct view of the angle that you're working on. But all of these devices, Omni, iStent, Hydrus, Miniject, Zen, you need to look either when you're placing the devices or to determine whether the placement is correct. So I'm trying to give you lots of reasons why you should actually be highly skilled in using gonioscopy. And sometimes when you put these devices in, you can inadvertently trigger clefts. So again, if you're going to diagnose a surgical or a iatrogenic cleft, then you'll be using gonioscopy in the clinic. And if you are repairing clefts, then again you're going to be using gonioscopy to determine whether your surgical repairs have been effective as well. There's fantastic resources available on the internet. This remains one of the best websites on learning about gonioscopy, fantastic videos, but I think a lot of people are starting to upload now on social media. So, you have got so many resources at your fingertips now to, learn how to improve your techniques. So, no excuses. And that's it. So I will have had some overlap with the subsequent talk, I'm sure, which is going to go more into conditions and findings of gonioscopy in different conditions. But yeah, so thank you.
Thank you very much, Dr. Huma. Our next speaker is Professor Syed Imtiaz Ali.
How important she was, but उसने उसकी कदर नहीं की.
The video is by Dr. Rashid.
Yes.
The background song is by Elvis Presley.
Yes.
Quite as good as I should have, quite as often as I could have. Little things I should have said or done, I just never took the time. You were always on my mind. You were always on my mind.
You were always on my mind. So same goes true about the gonioscopy. Are visible there on the left side, and you can see the cyclodialysis cleft as shown by Dr. Huma. This is the similar picture. And angle recession is very common in trauma cases, and you can explain the unexplained glaucoma many, many months after the injury has taken place. And again, a picture of angle recession. You can see the wide angle on the right side. And again, a good picture of the angle recession. You can identify easily. This is a glass foreign body in the angle which is shining. You can, nothing will explain the problem caused by this condition unless you do the gonioscopy. And this is another foreign body in the angle which has been lodged there. Marked pigmentation in trabecular meshwork, Dr. Aisha also mentioned in pseudoexfoliation syndrome. So once you see a lot of pigmentation in the angle, it could be either a pseudoexfoliation syndrome or pigment dispersion syndrome. In pigment dispersion syndrome, you will have other signs of pigment dispersion in the Krukenberg spindle and pigmentation on the endothelium of the cornea. If you have aniridia, then you can see the absence of the iris and you can see the ciliary processes there. And this is a picture of peripheral anterior synecdoche. You can see that this is slightly different from the iris processes shown by Dr. Huma. They were numerous, they were thin, and they were too many in number, but this is peripheral anterior synecdoche that can explain the unexplained glaucoma in a patient. Again, is a picture of pigmentary glaucoma showing a very heavily pigmented trabecular meshwork. Rubeosis iridis, sometimes it is, you cannot see the vessels on the iris surface or on this margin of the iris in rubeosis iridis. Very early rubeosis can be seen in the angle, and you can see even blood in the Schlemm's canal. You can see blood in Schlemm's canal in post-operative cases as well, and trauma in early cases, but in rubeosis, they will last for a long time. You can see a iris stromal cyst that is not visible otherwise. You can see it on the gonioscopy. These are different clinical conditions. And if you have a small iris melanoma, that can also be seen, and an iris nevus which is attached upside. And once you've done a surgery, you can see the peripheral iridectomy. Sometimes after trabeculectomy, you're not sure, and then you can do a gonioscopy and see your peripheral iridectomy is patent. And at some stage in your clinical practice, you see unexplained rise in the pressure after an injury or after a cataract surgery. So you can see the retained lens material in the angle. And that's very interesting. I have some interest in seeing KF rings. And at times it becomes, when I'm referred these cases, and sometimes it's very, very difficult to identify an early KF ring on just clinical examination on the slit lamp. So it was at times very difficult. And since I learned gonioscopy, if you can see very early signs of KF ring on gonioscopy. And then you can tell the physician if the patient has a Wilson's disease or not. This is a very, very important and sign that you see, which is called as Sam-Polizzi line, and you can see it in two conditions. You can see either in the pigment dispersion syndrome or pseudo-exfoliation syndrome. It's a marked pigmentation. Dr. Aisha also showed this in her talk. And your IOL haptic can be eroding in the lens, and you can see the haptic and identify it and reposition it. It can help you there. So once you've done gonioscopy, it can reveal many things, and काफी जो राज होते हैं ना उनसे पर्दा उठ जाता है. But as I said, it is not done frequently, and it is difficult to do and difficult to learn, but one will have to learn it. Thank you.
Thank you very much, sir. The next talk is by Dr. Rashid Zia.
So I'm not going to go into the details of the Imbert-Fick law, which determines the Goldman applanation tonometry principles. But the main problem with this, with the Imbert-Fick formula, was that they assumed that all corneas are the same. If we don't look the same, if we're not the same height, not the same sex, same race, then how could every cornea could be same? So that's why there are many problems if you look at the readings by the Goldman applanation tonometry. So how does the central corneal thickness affect the measured IOP? The whole problem started with Oates' study, where they said that a CCT is an independent risk factor, which is a complete load of nonsense. All we need to say sensibly is that a thin cornea will require less force to applanate than a thick cornea. Very common sense. And so we can say that if it's a thick cornea, we will need more force to applanate. If it's a thin cornea, we'll need less force to applanate, which means in a thick cornea, you're likely to overestimate. In a thin cornea, you're likely to underestimate. So if you look at the nomograms, which are available with the all CCT instruments available commercially, like I've seen Pacimate, which we normally use in England, and if you read a central corneal thickness of 630 microns on this, it'll give a correction factor of -7. So that's completely wrong. And if you look at literature, and you'll find that the different studies are quoting different correction nomograms based on the central corneal thickness. Some would say that there is a 5 millimeter difference by just 70 micron. Some would say 50 micron thickness will give a 2.5 millimeter. Others would say you need at least 100 micron difference and then 2. So why there is so much of difference? These researchers are genuine researchers, but then they're finding that each one has a different outcome from the other research group. So there's a whole lot of science behind it, which I'll try to touch today. So before that, oh, गाना तो लगाओ यार, voice किधर है? Hello, so कोई आपका sound on करे ना? See, this is what happens in clinics, and this is a worldwide problem. So the Association of International Glaucoma Societies, an intraocular pressure group, they have come with a consensus statement that measurement of CCT is important in assessing risk factor for incident glaucoma among ocular hypertensions in a clinical setting, although the association between CCT and glaucoma risk may be less strong in population studies at large. So this is very important because in clinical settings, when trials were done like Oates study and EGPS, they found that there is an association of CCT and glaucoma, but if you look at population studies like Sweden and Barbados studies, there was no. So we do not understand why there is the clinical setting, clinical trials do not correlate with the population trials, but possibly when you look at the population trials, they may have less people with thick central corneas. That may be the reason. So, and then in Oates study, they said CCT to be statistically important factor, which does not, this is what they mentioned, and this created the whole problem all over the world. And people started to think that this is also an independent risk factor, which is wrong, because to be an independent risk factor, you have to control every other risk factor. So you have to control the hysteresis, you have to control the race, you have to control diurnal variations, everything. And then come to say that this is an independent factor. So it's not an independent factor. It may be a statistically important factor, but even that's debatable. So this is what we have discussed, that on average, greater CCT results in overestimation of IOP as measured by the Goldman. And the extent to which CCT contributes to the measurement in individual patients under various conditions is yet to be established. So please do not correct. So how does CCT vary? CCT is one of the most genetically constant factor in human beings. So racial and ethnic categorization is imprecise, but CCT is one of the most highly heritable aspect of ocular structures. And you will find that the African Americans will have the thinnest CCTs, and whereas the whites and Caucasians, they have the thickest CCTs. And over time, some studies, they say that there may be slight change in central column thickness, which can, and then this created a lot of literature that as you grow older, the central column thickness changes, so the pressure changes. That's all a lot of nonsense. So please, this is again the same thing I'm repeating. The correction mammograms that adjust GAT pressure based on CCT are neither valid nor useful in individual patients. This is the consensus statement of World Glaucoma Society given by the world authorities. And the extent of measurement error in individual patients cannot be certain from CCT alone. So relationship between CCT and glaucoma risk or progression, the relationship between the CCT and glaucoma or the progression of glaucoma cannot be explained solely by tonometry artifact. And some people say that if you have thin central corneas, you may have a thin lamina cribrosa and hence a higher risk of damage. Again, that is a collider bias in studies that we call. It's not necessary that if you have a thin cornea, you will also have a more susceptible optic nerve damage. There's no evidence to prove that. And so this is a very interesting chart. I don't think you can see my laser beam, but anyway, what I'm trying to, yeah, I can do the cursor. So, yeah, thank you. So you can see the blue line indicates the 10 millimeter pressure line. The green is 15, and the red one is the 20 millimeter line. And over here you have corneal thickness, and on the vertical meridian you have the theoretical prediction of IOP readings. So what you can see, if you look at the this line, the 10 millimeter line, blue, this one. Okay, and if you look at the corneal thickness, now these are the pressures which are directly measured. So if you look at the corneal thickness from 450 microns to 650 microns, the error is from 8 to 9. How much is that? 8 to 10? Around 2 millimeters. So this is what a direct engineering studies where they put the normograms into the interior chamber, they found that you need at least 200 microns of variation in central corneal thickness to have a pressure reading difference of 2 millimeters of mercury. So now you can understand that how irrelevant is that and how overemphasized this is in the clinical practices. So that led to the development of the corneal hysteresis and look into the corneal hysteresis. This is a common instrument. I'm surprised that this is not available. It's not inexpensive. It should be present in our conferences to buy and purchase. It's like a puff air tonometer. And it's becoming a norm in the UK. Like in Moorfield, they only use this. In my practices, we only use this. And some patients where we cannot use this, we go back to GAT. And in certain clinical conditions, we also use GAT, but majority of the patients, this is what we use. So it has four readings, 1, 2, 3, and the smaller one is there. This is just the reliability index. So this is the IOP-CC, or corneal corrected IOP-CC, which takes into account the corneal hysteresis, which affects the intraocular pressure more than central corneal thickness. Central corneal thickness is one factor which out of many factors which affects the corneal hysteresis. So what should we give more attention to? Corneal hysteresis or a single factor which may or may not affect corneal hysteresis. So this is the, and this is the corneal hysteresis. Corneal hysteresis is a very dynamic thing. If the patient is unhealthy, there is disease, the pressure rising, pressure dropping, all those things can affect corneal hysteresis. There could be diurnal variation in corneal hysteresis. So when we read high pressures, low pressures during the diurnal range, which is not great, it may be just a difference in corneal hysteresis, because corneal hysteresis depends on dehydration levels. So if my dehydration, if I'm not, like at the moment I feel dehydrated, I may have very low pressure. I get a water drinking test, sorry, my head's up. My pressure may rise up because my corneal hysteresis may change suddenly and we may not be reading the right pressure. And this is the IOPG, which is very similar to the IOP Goldman. So this is a very, very useful, it's the same price as possibly a tonometer, Puffer Air tonometer, maybe slightly more expensive, but not an expensive machine. So previously we saw, how many, 4 minutes? So previously we saw the effect of central corneal thickness. Now we will see the effect of corneal hysteresis. So over here, this is the corneal modulus, which is the factor of the corneal elasticity. So the stiffer corneas, in stiffer corneas you read higher pressure, and soft corneas you read low pressures. So here you can see, again, blue is for the pressure of 10, actual pressure of 10. Green is representing actual pressure of 15. Red is presenting actual pressure of 20. And you can see as the corneal elasticity changes, the pressure can change up to 10 millimeters. Previously with CCT, over 200 microns, the difference was 2 millimeters. Here, slight changes and pressures can change up to 10 millimeters of mercury. So it's very, very important. And that brings me to the most important thing, is after the refractive surgery. So what happens in the refractive surgery, especially the LASIK, we'll just talk about LASIK, otherwise I'm running out of time. In LASIK, you remove corneal flap, and then you ablate and put the flap back. Now, there's always a potential space between the flap and the corneal bed. When you do GAT, or the Goldman applanatometer, what are you indenting? You're not indenting cornea. You're indenting epithelial flap. So you will read very low pressures. You are just not even indenting the cornea. So GAT, or Goldman tonometer, in LASIK is contraindicated if it's the wrong word or right word. So this is an example after LASIK surgery where they were reading pressures of 14. The actual pressure was actually 53. And this is not common. This is not the only single study. There are many clinical case studies littered in literature with this. And similarly, if you see a LASIK done for, let's say, 3 diopters, 4 diopters, so okay, the mean difference in IOP we were reading after LASIK was 2 millimeters. So you can see this line, this is 0. So you can see it's not much different. But look at the scatter plot. How much pressure is different? If I look at after 3 diopters, so the 25 millimeter. I do not know what I'm reading. So after LASIK, you can see how much difference, about 25, 30 millimeters of mercury variation could be there, and you just may not read it. So this is why it's very important. And that's why we come on to the thing that alternate tonometers are needed for refractive surgery. Similarly, I have just 1 minute left. So similarly, the other thing is prostaglandin analogs. Now, prostaglandin analogs, they alter the hysteresis because they degrade the extracellular matrix, they increase the tissue permeability of the sclera, they decrease resistance to aqueous outflow. So they reduce the corneal and scleral stiffness. The cornea is not as stiff, so you're likely to underestimate the pressure. And there are many studies where they say that you may be reading 2 millimeters or 3 millimeters underestimation after starting with Xalatan, Travatan, and they say biometapros is more effective because of different mechanisms, but they just do not keep in mind that it may be causing more extracellular degradation and causing a worsening of hysteresis. So I'll drop that here. I will just quickly show that if the cornea is soft, the central corneal thickness has very little effect. But if cornea is hard, the effect of CCT is more pronounced. So I'm not going to go into that. And this is the last thing. The central corneal thickness is just the tip of the iceberg. We cannot ignore the corneal biomechanical properties and ablation profile. Sorry. And this is what is that? This is just to say it's a song by Roxette. She died. It's a song from Pretty Woman. And she's saying that, oh, it must have been love, but it's over now.
It must have been love, but it's over now. It must have been good, but I lost it somehow.
Thank you very much.
Here as well. My name's Omar Rafiq. I'm a consultant from the UK, but I work in Moorfields in Abu Dhabi. We've actually got a Moorfield symposium on tomorrow, so I'd highly encourage you to all to come and be our honour. So I'm going to talk about a 4Ws approach, more kind of not all clinical really, but some simple things that sometimes are more important in terms of communication skills and very basic principles that we all see, but we sometimes maybe just ignore, not consciously, but possibly subconsciously as well. So I'm not going to labour the point, but the 4Ws essentially, so the first one is what? What is glaucoma? We all know essentially what glaucoma it is. And I think now, as I've got more experience and working in different kind of healthcare markets, being from the NHS is a different mindset. But now working in the Middle East, it certainly was an eye-opener for the last few years because patients' expectations are very different as well. And I've kind of realized that you have to gauge and get on board with the patients because if their understanding is very different to what you're trying to explain, because they'll come in with saying, well, I've got glaucoma. A lot of my practice, believe it or not, is telling or explaining to patients where they don't have glaucoma because they've just been overtreated and every single parameter is correct. And I try and explain this to my colleagues as well. Not every pressure of 20 or 21 needs treatment. So it's a bit like doing detective work. Dr. Huma made a very valid point earlier about gonioscopy, and I can't stress this more. Gonioscopy, doing the Goldman, the OCT, you're doing your structural tests, your visual parametric tests. These are all kind of things that you need to take all in tandem. So glaucoma is the leading cause of irreversible blindness worldwide. It affects millions of people, and this is probably underreported. And where is glaucoma? We obviously know exactly where the anatomical location it is, so I'm not going to labour the point, but it can be very much asymptomatic. There are many patients in all our clinics who may present or manifest for a completely different reason, either from the healthcare provider, the opticians, and they may just come for a routine eye check and they have high pressure. And then that leads you down a whole rabbit hole because they weren't expecting what you're about to tell them. So it's very important to firstly encourage regular examinations. So we were all brought up with kind of images like this. This is normal vision, and then you have the same view with somebody from glaucoma. But we can challenge that now and say that's not accurate at all. Glaucoma is a spectrum of conditions as well. This is a slide modified from David Crabb's work, which was fascinating. And you can see, patients will manifest with a multitude of different symptoms. And they may, and I regularly, and I'm sure we all have patients who present to clinic with vision that is very severe, and they've actually come driving, and it's trying to now explain to the patient why, especially in the part of the world I live in, why they should be driving big SUVs, and you don't want to be on that side of the road. So why does it happen? And it's a multifaceted approach. There are many things that you have to look at. The age, the IOP, hereditary kind of components. You've got oxidative stresses, you've got glutamate neurotoxicities, and I won't kind of go explain about the newer medications that you've got, especially with the nitric oxide compounds, but there's a huge amount of work that's going on into glaucoma, whether that's with laser or especially the MIGS approaches, which I'll talk about tomorrow. But it's explaining the why to a patient. Open angle glaucoma, I'm a Yorkshire person, so we kind of believe in very simple things. So open angle glaucoma, the trabecular meshwork looks normal, but it's like a tap in, tap out system. Okay, fluid is not presenting outside and there's a high pressure, it's causing damage. The angle closure glaucoma, once again, you have to do gonioscopy to analyze the angle, and it's very helpful to visualize exactly what it is that you're seeing. The one that I find challenging, and my practice has changed. In my UK practice, it was vastly Caucasian glaucoma, and it's pretty straightforward. But the practice that I lead now, especially with the diabetic populations that we deal with, a lot of patients are coming in presenting with very high pressures with secondary glaucomas, whether it's diabetic retinopathy related, vein occlusions, and they're heading straight for tubes. So they bypass everything. When you've got a pressure of 50, that's not going to do very well. You're not really going to offer that patient a trabeculectomy. So what next? So you've got very fine-tuned, I'll talk about the medical treatment. So a major problem associated with the use of eye drops is actually facilitation and compliance. And with my patients, I find that sometimes if they always present to clinic and the pressure is very well controlled, and they are progressing right in front of you. And sometimes I'll do serial visual fields, whether it's every 3 months, 6 months, if I'm really worried about a patient. And I sometimes I ask them a question, and I just say to them, look, and it's about engaging with your patient. And I'll say, look, I'm not here to judge you, but please tell me if you do miss your drops. And then they slowly start opening up to you, and they may turn around and say, well, yes, I do. I kind of put them in the last couple of days because they know that they are coming to see you in clinic. So that's a little top tip, just ask them. And you just have to sometimes say, look, it's fine. And I'll give them my example that, look, I'm sure I'd be the same if I need to take a course of antibiotics for 7 days. If you're fine after day 3, you might forget on day 4, and day 5 it's gone to the back of the drawer. And when you kind of put it from a human perspective, patients will tend to open up for you. And I think that's very crucial, because to know where you're going, it's very important to know where you're coming from, where your baseline is. And this is exceptionally important, because if I'm about to possibly kind of do an interventional procedure on this patient, an incisional approach, then post-operative management is absolutely key if they are not going to be compliant with their medication. Because sometimes, especially the population that I work with now, I have to keep them on post-operative steroid drops for many, many months. So it's about kind of gauging with your patient exactly what you're dealing with. Education can improve. There's a fascinating video that's on YouTube where they ask a patient to demonstrate to put the drops in. And this elderly lady's drop lands here. So she's correct. She is putting the drops in, but they're not quite going in the right position. And whose fault is that? If the lady is, especially in the UK, a lot of our patients are elderly, live on their own. So it's kind of looking not just at the eye. We are eye doctors, but we're doctors. Your consultation starts, mine does, when they are walking in to the room. I'm not on my screen. We make sure that we're not just not looking at attention. I pay attention to the moment the door opens. You stand up, you greet them. There's lots of things. Not only is it a very simple thing to do, but it really gets you on board with the patient. I always say, treat people the way you want to be treated. Smile at them. You'd be surprised how much they want to please you, and their compliance goes up. Compliance aids can help. We've got lots of them for, kind of especially the lubrication market. We're a bit behind within the glaucoma market as well. And something that was the bane of my life in particular was preserved medication. I'll always try and see if I can go preservative-free. Certainly, because and the way I kind of see it is, it's a bit like playing snooker. If you watch snooker, or you're not seeing somebody pop that shot, a really good snooker player is planting 6 shots down the line. So I'm not potentially watching for what's going to happen in 6 weeks' time with a red irritated eye. I'm looking at, in 10 years' time, for my colleagues, if I'm not around, what's going to happen with their ocular surface. Ocular surface is absolutely mandatory. It's one of the biggest things, for glaucoma compliance. You can have patients with a pressure of 12, but you can have a patient who's coming into your clinic the quality of life is horrendous, with red, sore, uncomfortable eyes. Can we really be happy with the service that we're providing? Not really, because yes, we might be happy with your glaucoma's fine, it's not progressing. But if that poor lady or that individual is really uncomfortable, you'd be very surprised. And I'll ask you in a very simple way. Imagine if you've got an eyelash in your eye now. You'd be rubbing it like mad and be uncomfortable. And this is what we're trying to tell our patients to do. No, you've got to live with it because your pressure is absolutely fine. So you kind of got to balance it up. And imagine, somebody who's got arthritic hands, asking patient with this. So, I always say, look holistically, look outside the box, look at who you're treating exactly. Will that patient actually comply? Will that person actually be able to utilize and put medication in? So the treatments that we've got many different options. I'm very lucky with what I have access to. We've got access to the micropoles, we've got access to the SLT, now the direct SLT coming in as well. We have all the MIGS approaches as well, and then you've got your drainage surgery. But in terms of the questions that I get asked is, and this is important, how giving bad news or giving news rather, you can sometimes give bad news, but in a very good way. And sometimes you can give normal news in a very horrendous way. We've all, as well as doctors, we've all been patients and we've all had experiences. And it's about making sure that, when that patient leaves, are they comfortable with the information? Do they understand? And another big thing that I do is, if you've got access to images in your clinic, or OCTs, kind of visual fields, that obviously they print out, but it's really powerful to demonstrate to a patient, for example, with my diabetic retinopathy patients, stressing to them the need for them to optimize their diabetic control. When you've got their fundus picture up in front of you and they've got, hemorrhages all over the place, you bet your bottom dollar they really do pay attention. So it's kind of, trying to gauge it with your patients and trying to get them on board. I always say, refer them to a low vision clinic may be beneficial. Consider partially sighted. I'm not sure in Pakistan how it is. It's very different. In the UK, we have an amazing low vision service with the RNIB. In the UAE, that market is not developed, so we are trying to work actively on that and making sure that those services and facilities are available to patients. And you've got to remember, this is a lifelong commitment. But glaucoma, once they've got it, you've added them to the pool. It's not like a cataract where you've done cataract surgery and then they've been discharged, back to the optometry service. And they ask, sometimes, can I continue driving? So there's all these different demands and conditions. You've got a patient who, I had a very sad case recently where I had a patient who was a pilot and was diagnosed with, came to clinic for a second opinion for glaucoma. And the pilot was from the Ukraine. And you can imagine if in the UAE you lose your license, you're going back home. And you can imagine what's going on in the Ukraine. So sometimes it's a case of, even though I know they are going to fail, it's about bringing them back and showing compassion and humanity. Because, we've all been there, we've given them bad news. You can't fly this plane, but look, finding another solution, maybe somewhere else. So it's simple things that I think matter. And this is nicely comes on to the fourth W. So we said the what, the where, the why, and I'm not going to labor the point on those to you because I think, you're all clinicians, you're all academics, you know exactly what that is. But I think the thing that I find really fascinating is people skills, communication skills. And the fourth W I coin is wow. So, you can have two different wows. You can have something really positive where a patient will walk out and be really engaged, or you can have somebody who's going to be really, really distraught sometimes with the news that you've broken to them. We get patients who will ask you, will I see again? Or these are patients who are bilaterally blind, or you've got somebody who's teetering on the edge, who is essentially has walked into your clinic. They are blind in one eye and they are essentially end stage in the other eye, and they need some intervention. Can you imagine, that what's going through that individual's mind? And if you're kind of looking down on the computer, not explaining things to them, and we say to our patients, look, feel free, here's our card, come back. We have that liberty of doing so. We have an open door policy. Just come and give us a call. Let us explain it to you again. Even on the day of surgery, we'll have kind of a mini sit down with them again and try and explain to them, because this is high risk and they are putting their trust in us as clinicians, and we can't do anything to really, break that trust. So in summary, our priorities as clinicians can sometimes be very, very different. But they're actually not, because when we trained to become doctors and healthcare providers, there was that ultimate aim. It was to genuinely help people. And you can sometimes help people not just by bringing their pressure down under control, but in many different ways as well. Kind of trying to engage with them, simple things about compliance, medication use. So let's not forget to treat the patient. Something very common I had very recently was a patient we see a lot of dry eyes, and he had floppy eyelids, and then you start asking them the whole spiel about sleep apnea, and they're like, how on earth did you pick up that from the eyelid? And we're thinking, well, this is actually very basic. And are you tired? And yes. So the whole consultation went down from dry eyes into why the relevance of their microvascular life to go and get a sleep study done. And they came and they come back. And they explain that they're positive and they have sleep, they wear a mask. And these are the kind of little things that I say, we are eye doctors, but we're doctors. We are doctors before we, kind of thing. So just never forget that. So visual aids are very, very powerful. And I'll leave you with this final quote. They say it's attributed to Maya Angelou, but it's actually not. Nobody really knows who it is. People can say they care, but it means nothing until they prove it. People are not stupid. Treat them the way you wish to be treated. And that was it. Thank you.
Thank you very much, Dr. Umar Rafiq, and thank you very much for coming all the way from Dubai to deliver your talks.
By Dr. Homa, Dr. Rashid, Professor Meher, and the mystery of the diagnosis of the glaucoma that remains there. I have worked on OCTA, and I have the OCTA, which has the software which can analyze the blood flow in the optic nerve head and the macula. So I am going to present one or two of my cases over here. How do we can early diagnose the glaucoma? So OCTA in glaucoma, the clinical updates on optic disc and macular vessel density. Optical coherence tomography angiography is novel non-invasive technique, provides non-dye based high-resolution 3D images of the retinal and the choroidal circulation. It allows precise mapping and quantification of the superficial capillary plexus and deep retinal capillary plexus, and shows abnormalities in the foveal avascular zone, and it detects the blood flow through the motion contrast generated by the red blood vessels. Although elevated intraocular pressure IOP is the main modified riskable factor for the glaucoma, high number of the patient also develop glaucoma with normal IOP followed by the vascular changes. पिछले 100 साल से we are discussing whether it is mechanical, which can lead to the damage to the optic nerve, or whether it is ischemic. With the advancement in the OCTA, we are able to see the vascular changes, and might be the vascular changes can help us in the early diagnosis of glaucoma. The macula receives its blood supply from the two main sources, the retinal circulation and the choroidal circulation, and so is the optic nerve. Optical coherence tomography angiography reveals vessel density in both optic nerve head and macula, and impaired microcirculation in the optic nerve head and macula may contribute to the initiation and progression of glaucomatous optic neuropathy. The other vascular factors include autoregulation of the blood flow in the optic nerve head and macula, the local vasospasm, the arterial hypertension, and nocturnal hypertension. Optovue Avanti OCT system with NGV provides us high-quality three-dimensional angiography using ultra-high speed swept source OCT, and this is an ongoing study in the vessel density at both Eye Care and CMH Institute of Medical Sciences, Multan. If we see the peripapillary vessel density, it is significantly reduced in open-angle glaucoma. The reduction correlates with the retinal nerve fiber layer thinning. The reduction that correlates with the retinal nerve fiber layer thinning and the visual fields, and similarly the vessel density loss often occurs before retinal nerve fiber loss, suggesting that early vascular compromise. The inferior peripapillary vessel density is a sensitive biomarker. So practically what happens is, when there is change in the vessel density, that change in the vessel density is going to lead to the retinal nerve fiber layer thinning, and that retinal nerve fiber layer thinning can affect the optic nerve head as well as the macula, and inferior peripapillary vessel density is a sensitive biomarker for the early glaucomatous changes. The superficial vascular plexus, we have two vascular plexes at macula. One is the superficial and other the deep vascular plexus. The superficial vascular plexus in the macula shows reduced vessel density in glaucomatous eyes. That is a strong correlation with the ganglion cell inner plexiform layer, and then it has a strong correlation with the central visual field loss. Why it matters? The macula it matters is critical for the central vision. Changes here may indicate earlier advanced disease even when visual field is still preserved. Now, this is the normal ISNT rule, that is the nerve, presenting the retinal nerve fiber layer thickness in inferior, superior, nasal, and temporal directions. And this is the vascular density at the disc and macula. The vascular density at the disc and macula that varies in metropic eyes, hypermetropic eyes, and myopic eyes, while at the level of the macula, it has got the superficial capillary plexus and the deep capillary plexus, and we can evaluate the vascularity at the both levels. Now, this is a disc macula combined picture. How to measure the optic nerve head and the macular vascular density? Now, this is the normal retinal nerve fiber layer thickness over here. You can see the inferior, superior, nasal, and temporal. And over here, this is the vascularity, and that is represented in a clock hours. Over here, you can see the grading in that clock hour type, and that represents that over here it is 50, that over here it is 45. Practically, it has to be above 50. If the retinal nerve fiber thickness is normal, then the RPC density at the optic nerve level that has to be above 50. Now, this is the macular vascular density, and the macular vascular density is represented at the level of the superficial and the deep plexus and the foveal avascular zone. So, practically, what I mean to say is, with the OCTA on the optic nerve head, we can see the RPC density and the RPC vascularization, while at the macula we can have the superficial capillary plexus, the deep capillary plexus, and we can also see the foveal avascular zone. Now, this is the first patient, 55-year-old male with open-angle glaucoma. It was on prostaglandins, but intraocular pressure was not stable. When he presented, it was 25 millimeter and 22 millimeter of mercury, grade 4. Right eye was 0.7, left 0.4. Now, you can see over here, this is the right optic nerve head, this is the left optic nerve head, and the macula. Over here, you can see the inferior part of the right optic nerve that is damaged, while on the left eye, it shows the normal thickness. When I studied the RPC density, I could see the infratemporal and the infranasal peripapillary zone showing patchy hypoperfusion. In the right eye, where it was already retinal nerve fiber layer defect, that could represent with the inferotemporal and infranasal peripapillary vessel, patchy vascular changes. And at the level of the RPC over here, this is marked in these circles where the perfusion was decreased. But in the left eye, practically the retinal nerve fiber thickness was normal, but still in that patient I could see this patch that was indicating the ischemic changes. This means the ischemic changes would have taken place earlier than the retinal nerve fiber layer thickness changes, and that is what is proving that we can detect the vascular changes earlier than the retinal nerve fiber layer thickness changes. Again, we are coming to the macular vascular density. The macular vascular density again represented in the form of scale. It should be above 50. Over here it is 47, and that represents vascular density in the right eye. And then over here we can see the ischemic zone. Now this software can represent the ischemic zone or the foveal avascular zone. So this is the right eye and this is the left eye. And these tiny patches, what are seen over there, these are the ischemic areas which are present on the macula. So similarly, we can see the non-flow area at the foveal avascular zone. The foveal avascular zone, that will be irregular and that will be enlarged. So we can say that in the form of the macular changes, we can see that in the superficial capillary plexus, the deep capillary plexus, and we can see in the form of the irregularity of the foveal avascular zone. Now this is the second patient, Mr. Imran, that presented at 18th of August 2025. Intraocular pressure in this patient was 25 on the right eye, 22, and this patient was sent for the second opinion. Now, this is the normal optic nerve head and the macular photograph of right eye, optic nerve and the macular photograph of the left eye. Over here, the retinal nerve fiber thickness of the right eye is normal, as well as the retinal nerve fiber thickness of the left eye is normal. But if we see the angiograph, RPC density, the RPC density over here in encircled area, that is deficient. So the ischemic changes, they have already started, while the retinal nerve fiber layer thickness, that is normal. So on the left eye, there is infra and supratemporal sector showing localized capillary dropout. Over here, this is the localized capillary dropout. But if we go back, both of the patients, they were having the normal retinal nerve fiber layer thickness. The vascular changes, they have already started. These are the maculas of the right eye. Again, the maculas of the left eye. I won't go in detail, but the both maculas, they were having an increased foveal avascular zone, and the both macular areas, they were showing the ischemic changes. Now, this is the increased foveal avascular zone. So practically, we can analyze the vascularity of the optic nerve head, we can analyze the vascularity of the optic nerve along with the macula, and even if the retinal nerve fiber thickness, that is normal, the ischemic changes, they will be presented. So interpretation of this patient is that there is definite evidence of the significant macular ischemia. There is a reduced vessel density at fovea and foveal avascular zone, and parameters suggest low perfusion. While in the left eye, there is evidence of mild macular ischemia and large of foveal avascular zone and no flow area, indicative some capillary dropout or reduced perfusion. I sent this patient for the cardiac examination, and on the cardiac examination, he was found to have left ventricular hypertrophy. This is the same patient I was showing there. So he was having the left ventricular hypertrophy. And then when I studied the literature about the left ventricular hypertrophy, I could find that the diastolic dysfunction can lead to the subclinical retinal and optic disc ischemia by impairing the systemic and ocular microcirculation. So the take-home message is the raised intraocular pressure contributes to the optic nerve damage by causing a mechanical compression of the lamina cribrosa, which deforms and compresses the optic nerve vasculature. So whether it's the raised intraocular pressure, it is going to compress the vasculature, and that vasculature can lead to the ischemia, and it leads to reduced blood flow. This mechanical stress can damage the nerve fibers, impair axonal transport, and ultimately lead to the death of the retinal ganglion cell or apoptosis. So we have the reduced ocular perfusion pressure, the microvascular dropout, the local hypoxia, axonal loss, and further cupping, enlargement of the foveal avascular zone of the macular ischemic changes, which accelerate the glaucomatous neuropathy. Optic nerve head vascular density changes can appear parallel to the macular vascular density changes appear. OCTA appears to be a promising technique for early diagnosis of glaucoma with an optic nerve head RPC density and vascular density of the macula. Early changes in the foveal avascular zone with areas of low perfusion are good indicator of presence of a retinal disease like diabetic retinopathy as well as a cardiac diastolic dysfunction. Thank you very much. Don't let glaucoma darken your life.
Can we finish the talks and then take the questions? Thank you. There's only one left.
Actually, I'm just started with this study, and I have done about 10 cases of such type. This patient which I presented over here, the second patient, that came by chance, and when I got the history of the cardiac problem, I did send him to that purpose. As the vascular changes, they can appear in the diabetic patient, in the cardiac patient. So at the moment, we don't have any very much clear view. But one thing is very much clear, the mechanical rise in intraocular pressure, that is going to compress the vessels, and that compression of the vessel, that will lead to the ischemia. As we say, the structural changes, they appear before the functional changes. Similarly, in certain patients, the ischemia can be the first thing, and then it will damage the retinal fiber layer thickness.
ग्लाकोमा हो कोई ऐसा भी केस है जिसमें नॉर्मल टेंशन ग्लाकोमा के अंदर कोई इस तरह की चेंजेस आती हैं या नहीं आती?
एग्जैक्टली इसमें यह है कि जब हम ग्लाकोमा के किसी पेशेंट को भी देख रहे हैं तो उसके अंदर प्रैक्टिकली हमने पेशेंट को एज ए होल देखना है। हमने पेशेंट को सिर्फ ये नहीं देखना है कि आई लेवल है, इंट्राफ्लोर प्रेशर है या लो इंट्राफ्लोर प्रेशर है। हमने पेशेंट की हिस्ट्री एज ए होल देनी है और अगर पेशेंट को हाइपोटेंशन है और इंट्राफ्लोर प्रेशर कम है तो उसके साथ ये चेंजेस आ सकती हैं। So when you are going to examine the patient, that patient has to be examined as a whole. Not only we are going to examine the eye.
So when we are doing OCTA of the disc, different machines have different modules, and depending on the scanner speed, it's not possible to have artifact-free OCTA. It's very, very difficult. So this is why OCTA is not really ideal tool for progression analysis, unless there is a huge change. But it's useful in low pressure glaucoma patients where you're scratching your head and you may come up, you're trying to understand what's going on. You may see a vasculopathy in early stages. But again, unless we are able to demonstrate a progression in subsequent tests, we cannot with authority say that this is a glaucoma patient.
This is the problem. So this is the problem with my understanding of OCTA, because I got OCTA and me and my technician, when you look at it, there are so many confounding factors that we are not sure that are we looking at the glaucomatous changes, or we are looking at the attrition with the age, or patient has hypertensive, diabetic, cardiovascular problem, and the medicine, because or we have a young patient, who doesn't have any other thing, pure glaucoma, and then we find out, and we find this patient extremely rare. So this is the reason we are always puzzled what exactly we are looking at.
Professor Joseph Flimmer, he has been the person, word authority on these ischemic changes, and I got the email from Professor Imtiaz, and I sent these cases to him, and now I'm working with his coordination for the further cases, and I think his work on the ischemic changes, that is much more authenticated.
We should look at it. I think you're doing a great job, and we should look at it in more detail. And then in future, it will tell us a lot of information. Especially in those cases,
It's because the problem is, when you have a floor effect, that the 40, 50 microns, and then the OCT cannot read it. I think it's important to look at the OCTA because that is changing beyond the that floor effect. What is the vascular change of?
Anyhow, with the time,
I think the time.
Any other questions or comments? Then thank you very much.